Hello, my name's Mark Fox, and it is my pleasure on behalf of Heinz Hammer and Jutta Keller, who led this guideline process, to welcome you to a panel discussion following the ESNM 2021 symposium introducing the new European guidelines for carbohydrate and 13C breath testing. Before we start, I should like to thank Kazim Aziz and also Adam Farmer for making space on the main program of the ESNM meeting this year for this session, the UEG for supporting us with a generous activity grant, and Novozyme, a company specialized in the production of enzyme supplements and probiotics, for supporting this meeting, sponsoring this meeting, as well as Fischer Analysen Instrumenten and Kibion. Without their support, we couldn't make the most of the material we have to disseminate it to our colleagues and to develop teaching material to support the development of this technology and its application wherever it's applied in Europe, and who knows, perhaps further afield. So with the formalities behind us, I'd like to kick off the question and answer session addressing Jutta Keller. So we have received questions from some of the faculty who've reviewed the talks, and the question I would like to start with is pre-test probability. In other words, how exactly do you use breath tests in your practice? Do you tend to use them to confirm diagnoses in patients in whom you're fairly sure have a problem, so a high pre-test probability, or do you do it the other way around? Do you tend to use them to exclude a somewhat unlikely diagnoses, or is this simply a standard part of your care? Jutta.
Well, actually, none of the above, none of the possibilities you mentioned, but most of the patients we see come to a tertiary referral center, so they have already received quite a lot of diagnostic testing before. This increases the likelihood of a functional disorder if all these previous tests have been found to be normal or at least inconclusive. So this already tells us that we will have greater chances to find a functional disorder in these patients. We do use quite a lot of function testing. We do use quite a lot of breath tests. It's what we regularly do in my laboratory, but it's symptom-based, and it's based on the fact that patients have no morphological, chronic inflammatory, infectious, or other diseases explaining their symptoms.
Right. And I may be wrong about this, but I believe you often use a panel of breath tests, lactose, fructose, perhaps other breath tests as well. As you know, it's not necessarily been proven that this directly informs dietary management, or maybe I'm wrong. What is your feeling? How do you apply this? What information are you gaining that you find clinically helpful?
Yeah, we are searching for distinct carbohydrate intolerances, for instance, because if patients lose their symptoms when just omitting, for instance, lactose, which is the most frequently found carbohydrate intolerance from their diet, they will be much freer to ingest different foods they enjoy than if they have to ingest, for instance, a low FODMAP diet. It's obviously clear that patients with irritable bowel syndrome will frequently need to avoid more than just one carbohydrate to improve their symptoms. But there are still several patients out there who just don't know that they have, for instance, lactose intolerance, and who clearly profit from a diet which is informed by the breath tests, or which is chosen according to the results of the breath tests.
Right. I'm curious to know whether other people do the same. And if I could turn briefly to Kristin, perhaps. You perform a large number of breath tests in Leuven. Do you have the same approach as Jutta, or is it very formalized in Leuven? Do you always run through a set of tests, come what may?
Well, first of all, I'm not a clinician, so I don't see the patients myself. We only execute and analyze the tests. But there is not such something like a fixed panel of tests. So it really depends. So sometimes the gastroenterologist asks a combined a lactose and a fructose test, sometimes only a lactose, sometimes only a fructose, so it depends. It's not that they standardly combine a number of bread tests.
Right. So the next question, just going back to Jutta, the alternative approach to a panel of breath tests could be to choose a substance, perhaps lactulose, perhaps the fructans, that could be regarded as a representative FODMAP, something that is not digested by anyone, always goes unchanged into the colon. And in that sort of situation, we're looking for symptoms, we're looking for breath tests increases. This is a different approach. Have you considered this kind of breath test management as an alternative to a panel?
Mm-hmm. Well, you are considering breath tests in the context of IBS. So you're
That is true.
You're actually expecting that patients will react to more than one specific dietary component, as patients with IBS frequently do. But we still have a number of patients who have just one specific carbohydrate intolerance, and we want to find those in order to be able to treat them accordingly. For patients with IBS, it would be helpful to find out whether they are carbohydrate in general or intolerant regarding carbohydrates which are malabsorbed. But I would not believe a lactulose breath test, because the amount of gas which is produced will be different. The transit time will be different. It can hardly be standardized. There are some data showing that it may be used to assess visceral sensitivity. We are using the Barostat device for doing this, and this is more standardized, and you can apply a better defined stimulus to find out about visceral sensitivity. We are not using breath tests for this indication.
Very good. I'd like to now move on to a series of practical questions, which were addressed to Johan. And given that his brother is present, I thought I might already turn to you, Heinz. But like I said before, all of you must feel free to chip in if you should have these questions in front of you. If you have other questions, please do come into the conversation. So one of our colleagues has written, patient preparation for breath tests attained a high level of agreement in the guideline process. However, these are mostly based on good physiological considerations and not really on clinical studies. So I'm curious to know, sometimes patients come and they're not properly prepared. Which rules are you prepared to break? And when do you always send the patient home? Or do you always do a baseline measurement? And frankly, if it's okay, then you continue?
Baseline measurements are always performed on breath tests and also on intolerance testing. We always want to establish the individual baseline at the day of testing before the tested carbohydrate is ingested. You are completely correct in that all of what we have summarized in the guideline with regard to rules of preparation is based on physiologic principles rather than on scientifically hard values. I think it is very important to maybe differentiate between what shall be done in potential future multi-center studies where a homogenized approach should be chosen, and this should also be demanded by potential future reviewers of future manuscripts submitted to scientific publications, which should follow a homogenized approach, for example, as demanded in our or suggested in our guidelines. This is one side. On the other side is the daily clinical practice, where, as you say, Mark, patients turn up and they are not 12 or 24 hours without food, and maybe they have smoked an hour before the test. And I think rather than sending them home, they have spent maybe an hour or 2 hours to come to the lab, and they have set time aside for a morning of 3 or 4 hours for this test. They have made the adjustments of the daily life for that. Rather than sending them home, I think for clinical purposes, it may be reasonable to start from a baseline and see whether when this baseline of hydrogen, for example, is within the range of less than 10 or 20, and then we can start the test and do it. But these then are test studies, are studies which may be helpful in the clinical sense, but should not be published in studies. So,
and here's a funny one. Well, not a funny one. It's just, I'm sure almost all of us do breath tests in the morning. That's just somehow the way they're done. But do you perform tests in the afternoon? And if you do, are the patients allowed to have breakfast?
We do not perform in our lab breath tests in the afternoon. They all start in the morning between 7 o'clock and 9 o'clock in the morning. If it came around that in the lab it should be done, that they should be done in the afternoon, it's a decision by the individual lab. It may be helpful, again, on the same basis as I said before. How long does the patient really have to be without food? Does it really, is 7 or 8 hours enough if we start the test like at 2 in the afternoon and 8 hours before, nothing to eat? It may be, and it may be enough for clinical purposes.
Seems like a long.
Should perhaps be possible if the breakfast does not contain carbohydrates.
Well, yeah, no, sure, no, that would be different. Yeah, I agree. That would be different. Yes.
That is an important remark. Yes, Jutta, I agree.
So with methane testing, I'm just curious, just here in the group, which of you uses methane always or almost always, in addition to carbon?
Only for scientific purposes, not for the clinical ones.
Okay. Well, Enrique, since you put up your hand, maybe I can address this question to you. So, as you know, the guidelines take a fairly neutral position to methane. It's not an absolute requirement, because of course that would have made the guidelines useless to quite a lot of people who don't have the necessary equipment. But what is your practice, and do you find methane very valuable? And just on a specific point, does the methane have to precede the symptoms, or is the presence of methane at any point in the study clinically important in your opinion?
Well, we get both results from the same patient. So hydrogen and methane, we get both. So we use normally only hydrogen, but we have the second result in case hydrogen is negative, in order to predict people who are non-producers, hydrogen non-producers. And in that case, we use methane in the same way we use hydrogen.
Right.
Which thresholds do you use? That's the reason why we don't use them. It's extremely difficult to find reliable threshold values.
You are fully right. I mean, you need to have a clear increase in the exhalation of methane. Otherwise, it's not reliable. You are fully right.
Christine, I think you did it.
May I? Yeah. Yep, may I get into that? We have started in my lab to do combined methane and hydrogen breath testing 3 or 4 years ago when we acquired a machine which can analyze both gases. The reason why I opted for this machine was to get into more deeply into the topic of hydrogen non-excretion and having and addressing the differences between detected intolerances and detected malabsorption. In fact, I had done intolerance symptom assessment since the mid-90s with my hydrogen measurements. And I always had seen those patients who had symptoms after a carbohydrate, but not hydrogen, but no hydrogen excretion. And I had seen that this was more than I had demonstrated to be hydrogen non-excretors, which in our area around 18 to 20% are hydrogen non-excretors after 25 grams of lactulose. But there were 30% of patients who had symptoms, but no hydrogen excretion. So this was the reason to go for the instrument which also does the methane testing. And it turns out that the collection of breath samples for this combined testing is much more complicated than it is for the hydrogen breath testing. It's more easier to perform the breath collection if you do only hydrogen collections. And with the combined testing, it may be difficult for elderly patients and for very young patients to have the exhalation, which needs to be for a certain time, and this is difficult. So we are now keeping this test, and my brother Johann in Vienna had done tests in the pediatric population, where he really did not see any advantage from including methane testing in addition to hydrogen testing. So it's very difficult.
So may I just, sorry to interrupt, Heinz, just out of curiosity, does anyone else have comments about methane? Because this is one of the issues which distinguishes our more skeptical European view from the American view, which is very pro methane, but that's partly because it was driven by Dr. Pimentel, of course.
Yeah. Not directly, just indirectly. When we calculated the hydrogen non-producer rate in our cohorts, it was less than 5% actually, with prolonging measurements for around for at least 4 hours, but only 10 grams of lactulose. So I'm really astonished that 25 grams of lactulose will not result in an increase in hydrogen in 20% of your subjects.
I'm
really
surprised about that too. My experience is more like Juta's. Christine, you wanted to come in?
I just wanted to say we also measure methane. Well, actually, just because we have an equipment that measures hydrogen and methane, but we do not report it, the methane, because we did a retrospective analysis of something like 1,000 tests just to see what was now, and we did not really find an added value. Now, I must say that we administer C13 labeled lactose and fructose and sucrose and measure both the C13 excretion as a marker of the digestion and the hydrogen as a marker of the malabsorption. And in that sense, we sometimes have people with very low digestion and no hydrogen, which are then the hydrogen non-producers. So we do not need the methane to detect the hydrogen non-producer. So that may make a little bit of a difference. But we did not really see an advantage of the methane measurements, and so far we still do not report it, although
we only report it in the case I told before, so that you see, in case it can be important for the physicians treating the patient. So if you get no hydrogen production at all in a specific patient, but a clear increase in methane, then I think it could be, we don't know, but it could be important for that specific patient just to know it.
Yeah.
Another question, somewhat related. How do you then interpret the occurrence of symptoms that are not associated with hydrogen or, for that matter, methane? Heinz.
We have to assume that part of these symptoms may be related to a perception of intestinal contents in the small bowel. And I'm referring to this study. I think it came from Robin Spiller's group 3 or 4 years ago, where he tested fructose and fructans, so that is polyfructose molecules, in I think it was healthy people and IBS, and did magnetic resonance imaging, where he could demonstrate by magnetic resonance imaging dilatation of small bowel loops after small molecular fructose, which caused an osmotic shift of fluids in the small bowel into the lumen, resulting in distended loops of bowels, whereas polyfructose fructans caused a dilatation by gas in the large bowel. So in the past, we had always considered that malabsorbed carbohydrates would only have a biological, pathologic effect after they had reached the colon, with bacterial metabolism happening there. And we had forgotten about potential osmotic effects of small molecular carbohydrates in the lower small intestine, where distension then also may result in symptoms. So this would be a hypothesis which certainly has to be researched in the future.
I was involved in I was working in Nottingham at that time, and the majority of symptoms was actually still associated with gas production. But I think there is a group of people who just, it can be the stomach, of course, that's distended. It depends on the volume of the test meal. I get the feeling this simple pain on distension goes in the direction of functional dyspepsia and the kind of thing that can be picked up by a barostat if you're brave enough to perform a gastric barostat. I'm looking at you, Carolina.
Yes. But I do agree that.
Do you have any impression, because you do a lot of gastric and intestinal, where do symptoms come from?
Well, I think they probably come from they do come from the stomach in dyspeptics, but I do think that IBS is mainly in the small bowel, or at least as much as the colon, and I'm sure that distension of the small bowel and increased water content, as Robin detected, I'm sure that does produce symptoms. It may produce diarrhea. So maybe some of the symptoms that these patients have after the breath test does come from the small bowel. That makes a lot of sense to me.
But we will come back to you about the small bowel a little later. We've already gone up to 20 minutes or so, so I want to move the conversation on to the most controversial part of carbohydrate testing, which is small intestinal bacterial overgrowth. And then in the second half an hour, Jutta, if you don't mind, you may lead the conversation on the 13C, that the part of the process that you led. But before we get there, small intestinal bacterial overgrowth. So I was going to ask Loris, but he's not here, so I shall ask the group. What are the pros and cons of using glucose or lactulose for the assessment of SIBO? And can either test actually be trusted to provide reliable results? Or are we all really simply doing these tests informed by the clinical history, the pretest probability, and simply sort of trying to confirm our impressions. Perhaps Enrique, would you like to comment on this first? Enrique.
Well, I would like to send the question to Jutta, because she was talking about that in her presentation, and I will comment on that.
Okay, yeah, and it's just something which is really important to me and also to our patients. We do use the glucose breath test searching for SIBO in patients with chronic diarrhea, for instance, and with bloating and abdominal pain. So we just don't always rely on the fact, or just don't limit the performance of the test to patients who have, for instance, small bowel diverticular, just to prove that there is small intestinal bacterial overgrowth, but we also use it for a differential diagnosis of SIBO caused by something specific, which we may not be able to detect, which then causes symptoms in these patients. We use glucose because it is much more specific, according to the data I know, than lactulose for SIBO. There are no direct comparisons of glucose and lactulose, except some studies comparing these tests with also bacterial cultures in patients with IBS. And the study I'm talking about found around about a 5% rate of bacterial overgrowth in healthy subjects, the same rate of positive glucose breath tests in healthy subjects, and much more. It was something around 40% positive tests in healthy subjects with lactulose. But there are, and you know this well, Mark, because you've contributed to some of these studies, there are comparisons where glucose and lactulose have been given together with a scintigraphically marked meal or radioactively marked meal. And it has been shown that in subjects with a healthy or a normal, not morphologically altered GI tract, the specificity of the glucose breath test with a higher dose than that what we recommend in the guidelines is 87%, whereas the specificity of the lactulose breath test in the same condition was around 10%. So there is a marked difference in my experience, according to the data I know.
I will say that if I was using either test alone without imaging, glucose would be my choice. I completely agree. I never do. My experience is that neither of them can. I mean, I can see always equal transit time. I had a young woman with IBS, or maybe she's got gallbladder diarrhea, but it was through in 30 minutes.
Yeah, maybe
the diagnosis would and she had no SIBO, but she had a perfect cutoff. As soon as the contrast arrived, we take measurements every 10 minutes because I can, and we take image, not with scintigraphy. You'll all be shocked, but with a fluoroscopy, we just check when the hydrogen increases. That's when we take a shot. Sometimes we take a shot if there's a clear uptick in symptoms, even if there's no hydrogen, because of course there are the low hydrogen producers, and for that reason, because we do imaging, I always use lactulose because it gives in my hands a clearer signal than glucose, because of course glucose gets absorbed. Traditionally, it was always thought in the proximal jejunum. We know that's not strictly true now, but nevertheless, on that basis, I chose lactulose because we know it cannot be absorbed, and so we get a clearer distinction between these various entities that we're interested in. At least that is my interpretation. But wait on my large scale personal series.
And what do you add to your solution to be able to make it visible on radiography? Do you add something up, which is
Telebrex? Yeah. It's a straightforward, commonly used radiographic contrast agent.
Both not something which also accelerates the small intestinal transit, because lactulose does. And if you add
well, I'm sure
certain
both of them do, but we're not really interested in the orocecal transit time, or at least we are. We recognize that these entities both accelerate transit. At least it's very likely that that's happening, but we have normal values. So, you know, we're simply comparing normal values. The normal values are between 50 and about 120 minutes, which is actually very similar to other quotes for orocecal transit
is
time.
exactly what you find with H2 breast testing with lactulose for orocecal.
So I don't think it's massively abnormal, the situation we're testing. And
so
what I
might
don't
ask,
do,
for instance, Heinz, what he thinks about it.
Yeah, I think I had always used only glucose for SIBO testing, for the reason that lactulose in all cases gets into the cecum and is metabolized there by bacteria, except for the hydrogen non-excretors. So I did not use lactulose for this purpose. For these special circumstances, as Mark has presented to us, where he has the opportunity to have the timely association to check for the association between between the hydrogen signal, the increase in hydrogen, and then at this time see whether this the radio-baked material has arrived in the cecum or not. I think it's reasonable, very reasonable, to use lactulose. Because with glucose, you may have the disadvantage that you would not reach the lower parts of the small bowel and therefore miss bacterial overgrowth, which is only affecting the lower parts of the small bowel. So it's, however, the question is whether the method Mark uses can be more broadly used in other laboratories. It couldn't enough. Well, we could, but yeah.
We could hardly, because we are frequently performing 5 or 6 glucose tests in parallel, and we could not all position these patients near the radiography unit.
No, that would be a problem. We only do 2 at a time, and my techs can use the fluoroscopy equipment, and but I fully accept that this is a luxury that not every department has.
May I add something, because the question was initially to me, and I sent the question to Jutta because actually we have done a lot of glucose and lactulose breath tests years ago. I'm not so, I don't trust so much this breath test, and actually we think on SIBO mainly in patients with a high probability of SIBO after surgery, or patients with, for example, pancreatic exocrine insufficiency or motility disorders and so on. And frequently, I must tell you, in our clinical practice, frequently we treat these patients empirically, and we use the breath test for selected patients in whom we are not sure whether they really have SIBO or not. And in that case, we use the glucose. But probably I will start to use your method, Mark. And
well, I mean, if that, I will happily send you my standard operating procedures if you would like.
Yes, I will.
So just on a related issue with the treatment of SIBO, are we treating these people with antibiotics always, or do we choose to use other approaches? And if we use antibiotics, which antibiotics do you favor, Enrique?
Well, if symptoms are severe enough, yes, we use antibiotics, obviously. And our first step, our standard practice is to use rifaximin as first step. Generally speaking,
myself as well, but of course it is quite expensive. Is that everyone's choice?
As far as I know, you can prescribe it. Isn't that the case?
Yes, it is.
Yeah. Very good. We're quite
very good.
envious.
I'm fully in support of what Enrique has said, and that's also the clinical practice in my hands, that I'm limiting my glucose breath test for SIBO to patients with a high probability, pre-test probability, and this is surgical patients, this is severely diabetic patients with abdominal symptoms. I do not have the typical IBS patients on my list of patients in whom I would perform a glucose hydrogen SIBO testing.
Perfect. All right, I'd like to draw this first part of the discussion to a close and move on to 13C measurements. Just before I hand over to Jutta, I'd very much like to thank Paul Afolabi and Christine Rebecca for providing not only an excellent discussion, but also a clear introduction to the performance and analysis and understanding of using these breath tests, which won't be familiar to all of our delegates. So I got several comments about how much they appreciated this. So with that said, Jutta, would you like to lead the discussion on this part of the process?
Yes, certainly. Paul, one of the questions that was addressed to you is the inter-individual variation of C13 breath tests for normal controls can be high. How certain can one be that test results provide a clear indication of abnormal physiology?
So thanks very much for the question. So in my research clinics, when I've been involved in setting up breath tests to look at liver function, particularly in non-alcoholic fatty liver disease, one of the first things I always do is to actually run like a small study to ascertain the coefficient of variation of that specific breath test in healthy individuals. Because without that information in place, I would not really be able to distinguish, the difference between those with, impaired liver function from those from healthy controls. So I would say that if it's possible in any research lab using a breath test, that they must first of all establish what is the intra-subject variation or the coefficient of variability of that specific test they want to do. Because it may differ from, one research center to another, but it's vital that each center gets that information first so that they can make an informed choice when they use that same test in patients with, a disease condition. And if the difference between both groups, which is i.e. the healthy group from the patients with the disease of interest, if the difference is more than the variability or the CV of that breath test in a healthy population, then it provides more certainty to say that there's a difference between both groups. So it helps better inform the researcher or the clinician in establishing confidence that their breath test is picking up the disease of choice or of interest.
And in comparison to other non-breath tests, liver function tests or liver tests in general, can you tell whether breath tests vary more broadly or is it comparable?
It's very comparable. So we published in Southampton both the variability of the 13C ketoisocapillary breath test, and we got a variability of about 13.4% in about 10 to 15 individuals over a period of a month. And when we looked at the data, it was comparable with the liver function test, which was about 14% as well. So we were quite confident that, what we hopefully will see is that the difference between those with liver dysfunction and those in healthy volunteers, anything above 13%, that difference or
So
even
it's
greater
actually
than that.
almost identical, isn't it?
Yes.
The variability of breast test for liver function and other liver function tests. Yeah.
Yes,
Yeah.
yes.
You've excellently presented the methodology of breast testing, cystatin breast testing, and I think for people who are new to the field, the methodology may sound quite complicated, but in our hands, the performance of the test is actually quite easy. Patients just eat and breathe, and then we adjust the samples to machine, and we will get the results automatically. What about liver breast testing in your experience? Is it complicated, or is it something, cystatin breast test, liver function testing? Is it complicated, or is it something you can include in your clinical routine?
We've been working on it as we speak to even make it much more simpler. For example, the 13C ketoacyl breath test is very simple. You make it up in 200 mils of water. It's mostly tasteless to the patient because we ask them whether they have a taste or not. They mostly say they can't taste the mixture in water. It's given directly to them, and they sit in the chair. And so everything is made for the patient to be comfortable to interact with the test. And while they're interacting with the test, we talk to them to, give them a background or the benefit of using the test. Because where our interest is we want to translate these tests from a research setting in the future into routine clinical practice, where it helps the hepatologist make a better informed decision in a very, very short period of time, that, where these patients will be going towards the pathway they'll be taking to. Is it going to be for surgery, or is it going to be a lifestyle choice intervention, or does it need a pharmacological intervention? So the patients are very, very appreciative of that, and they're very attracted to doing the breath test because of its simplicity. As I said, very simple, mixing it in water, they drink it, they blow into tubes or into bags for no more than an hour, because we know that they have a time constraint as well. And we're even looking to reduce that time point to hopefully in the future 30 minutes. So
this sounds really, really very comfortable for the patient and very easy to perform for the clinician. So
yes, absolutely. And the clinicians as well is also, sorry to add to it, the clinician is also very interested in the whole application, because he can see that it helps him, manage his time better and able to get what he wants to get out of the patient a lot quicker and a lot faster.
Yeah, we are looking forward to the use of cystatin liver function tests in the clinic more frequently and more broadly. So, yeah.
Yes.
And Christine, I'd like to ask a similar question to you, because it was also asked by one of our colleagues about the variability of cystatin breast tests for gastric emptying measurements, whether it varies, the results in healthy subjects vary more broadly than, for instance, scintigraphy data.
No, it depends a bit on what you determine as the results. So you have the variability in the C13 that you get into the bread. That depends, for instance, on the dose that you administer and on the CO2 production of the patient. But in a gastric emptying test, the height of the curve does not determine the gastric emptying half time. Mm-hmm. So the half time is only determined by, the only assumption that you have is that the CO2 production remains constant during the test. And so the height of the curve and the amount of CO2 that you have, the absolute amount that you recover, does not influence the half emptying time. And in that sense, so the variability is real variability and is not bigger than, it's similar than in scintigraphy, for instance. Mm-hmm. There is a high variability in the amount of C13 that you recover in bread, but it does not influence the half emptying time. And that is the main advantage of the test, I would say.
Yeah, the coefficient of variation for gastric emptying time measured by scintigraphy or breast test is around 15 to 20%. That's correct?
Yeah.
These are the data I've read before. So it's again, it's actually similar to other function tests.
Yeah.
You've reported that there are different test meals and test substances that we can use in different types of analysis. And one of our colleagues wants to know what is the ideal test meal and marker, and can we all agree to use the spirulina test? Do you agree that we should all use the spirulina test?
The spirulina test is a test that has been approved by the FDA and that is used in the States. I think in Europe we are more used to use octanoic acid as the substrate. A substrate is appropriate when you can show that it leaves the stomach together with the meal. That is actually the main requirement for having for a good substrate, and that is the case for octanoic acid, and that is also the case for the spirulina. So I think that both substrates are feasible. The advantage, I think, of the octanoic acid is that you can easily incorporate it in different test meals. So when you use the gastric emptying test in routine, then you need a standard test meal, but you might also want to measure gastric emptying rate of other meals for research projects. For instance, like we plan now a project where we want to measure gastric emptying rate of different types of bread. And that's easy. We can incorporate octanoic acid in the dough of the breads and we can measure that. So it really depends a bit on why you want to, what the purpose is of the test. For the daily clinical routine, we use the egg and omelette.
Mm-hmm. Yeah, some hospitals do
standardized.
Some hospitals, at least in Germany, do have problems with using egg substance for because there might be some bacteria contaminating it or something like that. And it's also a problem that certain octanoic acid is not pharmaceutically or is not available as a pharmacon, at least not in Germany. You can do this for your own patients, but you could not sell a test to somebody else to perform the test in his or her patients. So this might be an advantage of the spirulina test because it is a fixed and commercially available test, though not in Germany and not in Europe as far as I know. Yeah. It's licensed,
so that
or it's EU. Yeah, it's accepted but not available. Mm-hmm.
What we do now in Belgium, what we are now currently doing is that we buy C13 octanoic acid and then it's reanalyzed by a certified lab to give the statute of a pharmaceutical ingredient.
Yeah, that's what we do also, yeah.
And that is how we solve that problem now. We don't sell tests. There are no bread tests commercially available in Belgium. It's not available.
Except in urea, I guess.
Even that is not yet available in Belgium.
Okay.
Oh,
so
it's coming.
May I ask how many of our panel do use C13 breast testing for gastric emptying testing? For instance, I know, Enrique, you do.
Well, we have done many, but just for research, not for clinical practice.
Not clinically.
And one of the reasons is what we are now discussing, which is one of the most important issues with C13 breast testing, because none of the substrate except urea are commercially available. And the only way we have to get this substrate is in the context of a research study and the approval of an ethical committee. Otherwise, we have no option to use it for clinical practice.
Okay. Yeah, we can do it in the same way as Christine by having the substances reanalyzed in a pharmacy from which we buy it directly and just use it in our own patients. That's possible. What about you, Carolina? Do you use C13? No, and Heinz?
We only use scintigraphy. We don't use any C13 techniques. In fact, I wasn't familiar with them, and I found it very interesting.
Okay.
So I wanted to ask, so how do you overcome, I mean, in the future, if we want to translate these breath tests into routine clinical practice, and having just heard what you said about the 13C substrates are not available commercially, is there any discussion about how one could, or how the group can create a system whereby these breath tests can be used in a way that can be used in clinical practice for the future? Because I have some clinical colleagues. Yeah.
Sorry. I mean, it's the same as any new medical procedure, but complicated by the fact that you're using quasi pharmaceuticals. So this would have to be approved by Eurotop, by Euromedic, and then it would be available in Europe, which is not going to help you at all, Paul, because you're now in Brexit Britain. Although
Yes.
probably you will actually be, probably because of the politics, you might well get things done quicker in Britain than they would happen in Europe. And we'd be very grateful if you would do that for us.
Well,
because then we can just follow, because then we can just take all your paperwork and translate it. Yeah.
The spirulina test is CE marked. It's a decision of the company that it's not distributed in Europe. So it could be actually quite quickly if somebody had the interest to distribute it in Europe too. So there is some progress, but still quite a lot to be done and to be harmonized.
Yeah. And also to be reimbursed, because we here may do this as part of studies. I did this regularly all the time in Zurich, but not here in my private clinic. I only ever do this in Zurich because here I can do it, but no one's getting paid, and that is a problem if you're doing a routine clinical test.
Heinz, you want
development of this field really is inhibited by these technical difficulties which came out in this discussion. We also tried to look several times in the past years into opportunities to start for clinical purposes a gastric emptying test. We had done this scintigraphically in the 1990s, but we lost this scintigraphic opportunity, and now we haven't had a clinical opportunity to measure C30, to measure gastric emptying. And I'm happy to have the opportunity to discuss this here. And I think, Jutta, I may contact you in the next days to ask you for your protocol. And I think rather than establishing it again on our own, I think I would like to ask you to be able to draw on your experience, if you agree.
Yep. Yes, of course. Yeah. Yeah, and I was quite impressed by the last slide that Paul showed, showing all the opportunities we might have using C13 breast tests. So this is in contrast that we have practical concerns and difficulties to actually use it in the clinic, get it reimbursed, which is not unimportant. But this is in contrast to the actually broad possibilities that are attached to these tests. But we may have to move on to Enrique and C13 mixed triglyceride breast test, C13 pancreatic function breast test, which is another important aspect of breast testing and another important way to actually use them. Your talk was obviously really clear. It was really clear and with many aspects concerning pancreatic exocrine insufficiency and the performance of the breast test. The question we got for your talk is, please explain the use of C13 triglyceride breast test to monitor the use of pancreatic replacement therapy. Is this affected by patient physiology, severity of exocrine insufficiency, or simply how well the test marker mixes with the PERT, with the enzyme replacement therapy?
Well, this is a very good question, because to me, this is one of the major indications of the C13 MTG breast test, is to evaluate the efficacy of pancreatic enzyme replacement therapy mainly in patients with an insufficient response, those patients who are not doing well on therapy, and we want to understand why is that. And the idea is to perform the breath test first without pancreatic enzymes to have the baseline, that is to know what is the physiology of the patient. And then normally 1 or 2 weeks later, we repeat the breath test on pancreatic enzymes. And we provide the enzymes with the test meal. So the patient is doing the breath test with the exogenous enzymes. In that second test, of course, both the endogenous pancreatic secretion and the exogenous enzymes are contributing to the final result. But you can compare both results in terms of number, how much pancreatic function or fat digestion improves, and in terms of dynamic, because it's very nice the test because you can know exactly, or you may have a very good idea on where pancreatic enzymes, exogenous pancreatic enzymes have been released. Sometimes we have seen that the release of enzymes is very distal, and that's why the efficacy is very low. And this is something that we cannot improve just by increasing the enzyme dose, for example. So I don't know if I have answered your question properly.
I guess so. You did. It's obviously answered it perfectly. Some of your own research has shown that using this repetition of breath testing with increasing doses, with this method, you can actually optimize PERT therapy so that patients do no longer lose weight and actually gain weight as a clinical marker.
You know, I must tell you, I'm a really fan of the C13-MTG breath test, so probably I'm biased, although we have a lot of data on that and we have published quite widely. Yeah, the point is, in clinical practice, what we do is when we prescribe pancreatic enzymes, is to repeat or to visit the patient again a couple of months later to ask for symptoms and nutritional markers. And if the clinical response was not the one that we expected, then we repeat the same couple of months later after increasing the dose. So it may take long time, even 1 year, to titrate or to individualize the therapy, the pancreatic enzyme replacement therapy in individual patients. We can do the same in very few weeks or just in 1-2 weeks by using the breath test. Why? Because we demonstrated in one of our studies that if the dose of enzymes is able to normalize the breath test result, that dose is the one that the patient requires, or the minimum dose that the patient requires to avoid symptoms and to normalize the nutritional status.
So you can directly use the test to optimize the treatment. And
to titrate and to individualize the therapy. Exactly.
Yeah,
would you all agree that in all the fields that 13C is used for, that it is this ability to repeat testing, to optimize within the individual? Because I mean, within the individual, all the other variabilities of metabolism disappear normally, and you can really do what you just described, Enrique, in pancreas testing. And I suspect also with gastric emptying, it's particularly reliable to see the response to therapies. And to correlate that with clinical response, is really an attractive technique for this. I'm slightly concerned about using it as a simple replacement for direct measurements of gastric emptying like scintigraphy, because in our hands we found some discrepancies, but not within the individual. We always got very reliable effects, let's say before and after a prokinetic.
You need not be concerned. Of course, it's not the gold standard, but it's Christine has shown a 0.89 correlation coefficient between scintigraphy and the C13 breath test, the octanoic acid breath test. So of course, it's not the standard, the reference standard for all these tests, because it's indirect, because you have these other metabolic processes which also contribute to the result, but it's quite good. Yeah, and
it's safe and cheap, actually.
You are fully right. You are fully right, Mark. And I will tell you something even a bit provocative. To make clinical trials, to carry out clinical trials using the breath test to test new drugs, new products is so simple, much easier than any other test. So, of course, if you can repeat the test several times with several doses, for example, you can do a clinical trial in a very short time compared to any other methodology. So, generally speaking.
Yeah.
The point is that no breath test is the gold standard for nothing.
Yes.
Well, that's true.
Yeah.
And
yeah, the cystinuria breath test is really good, although it's not the gold standard, of course. Yeah.
Yeah.
And talking of a lack of gold standards, that sounds like a good moment to move on to intestinal motility, where it's a wonderful kind of wild west of new technologies and new applications. So, Carolina, I mean, obviously, I think we all feel the small intestine is the black box, and there may well be all kinds of things going on there that we can't see. Are we right? Are we actually not testing the small intestine, basically because we don't have the technology? And how are you finding using high resolution manometry for this indication? How frequently do you find big surprises, new diagnoses?
Yes, I truly think that the secret to at least some of the functional diseases is in the small bowel. We are using these new technologies, and I'm especially excited about the high resolution manometry in the small bowel. We have just published recently our results in healthy volunteers. So the clinical value of this test has to be established, and I think it has to be tested in more centers. And I would like more centers to start using this technique. It's quite easy. If any center that does perform small bowel manometry can definitely perform high resolution manometry. It just has more sensors, but it's a very similar catheter. And the difficulty with this test is probably more related to the interpretation of the recordings, which is a bit difficult, but of course can be learned. And I think that high resolution will bring the same or at least similar results to what happened in the esophagus, hopefully, where it has been a revolution in the diagnosis of motility disorders, and hopefully we will advance in this less known area of functional bowel disorders.
So do tell us just a little bit more, because I think many of us don't do this because we're sort of inhibited by the potential complexity and the length of time. I mean, is this a water perfused catheter? Is it solid state? Yes. How do you get it into place, and how long are the studies?
Yes, we decided to use water perfused technique because the solid state technique is probably too delicate to be in the small bowel such a long period of time. And of course, the catheter would be bended and it could break easily. So we decided to go for water perfused. We are using the same system as the water perfused esophageal system. So actually, if you have that, you can use the same system, and you just have to get the catheter. It is a long test. It takes 5 hours. 5 hours once you have the catheter in place, and we usually take about 1 hour to get it into the jejunum. But it's not difficult. I mean, we don't use endoscopy. We just use fluoroscopy, and we just push it down. So it's not. I think, I'm not sure, or I don't understand why this is not being performed at more centers, because I think it does bring important information when you diagnose intestinal dysmotility, a dysmotility disorder.
Carolina, we are using a catheter with pressure transducers on the catheter, and it also has impedance measurements, so that we could, I don't usually do that for clinical reasons, but we could actually analyze the association between motility events and flow, except that if the small bowel is just full of liquid contents, then we don't see an impedance signal. But otherwise, we can actually perform the analysis you're proposing, and the catheter is quite stable, and we use it lots of times. Yeah.
That would be very interesting to test, because with the high resolution technique, we are seeing these propagated contractions that we didn't see before. And I think that they probably have an important role in transitive content and symptoms. So we should try to do some research together. That would be great.
Certainly, yeah, great. I actually mentioned some patients with a clear impedance signal in relation to these propagated contractions, but only some, and I didn't have a systematic look at these data so far. But maybe I will.
One of the cases you showed was particularly interesting to me, which was I think you showed a case where the patient failed to respond to a meal. In other words, the MMC just continued to happen, or at least contractions that looked like an MMC. I think Magnus Simon described that years ago, but it was never really followed up. And I have a lot of patients who I feel have a problem that goes like this. How often have you seen that? And do you recognize, does this cause symptoms? Does it seem to cause symptoms?
Well, with conventional manometry, we used to see this pattern as clusters of contractions, but we didn't see the connection between the different sensors. So we didn't know if those contractions were propagating down the small bowel. It's something called minute rhythm. I'm not sure if any of you have heard of that. And we usually see it in patients who have intestinal neuropathy is actually the #1 diagnosis. We haven't correlated that with symptoms, but one would think that could give diarrhea, of course, because these strong propagated contractions after the meal probably move food rapidly down the small bowel. We'll keep working on that.
And Karene, if you see phase 3 activity after a meal, you also interpret this as a sign of autonomic neuropathy, don't you?
Yes, definitely.
Right. And I mean, just to get your opinion, obviously smart pill, it doesn't acquire anywhere near as much information about pressure, at least, but it does acquire some pressure measurements. Do you feel that this could be any help at all? Some kind of simpler alternative to this prolonged test that you're performing?
Well, maybe it could be helpful in cases of severe hypomotility. I mean, there is some data on this, and as most of these tests, the range of normality is very large. So you only get abnormal tests when things are very reduced. And in the case of the number of contractions in the small bowel, this happens. So it could be helpful for severe hypomotility. In this case, usually transit of the capsule is also delayed, and you could get a diagnosis. But I don't think it would be very helpful in the case of a neuropathy or other disorders that we can diagnose with manometry.
What about imaging? I mean, MR imaging is becoming more widely available. And there are Alex Menis, who's chairing another session at this meeting. He's been showing how you can use artificial intelligence essentially to make sense of the complex movements that are observed in the abdomen, the small, also, of course, in the small bowel, also other organs. That, of course, is the inverse of manometry in a way. But do you think that you're gaining unique information, or do you think that it might be possible to see some of the same things using imaging?
I definitely think that imaging is part of the future, because it is a test that can be widely available almost anywhere, and we should keep working on that. Oops, excuse me. The problem with magnetic resonance is that you only get a few seconds of recording. So I mean, you're recording a very short period. Well, it can be prolonged to minutes, but I mean, it has nothing.
Like you. No.
Yeah. So again, I think that we probably have a problem with only detecting very severe cases, but I do think it could be helpful, especially maybe as a screening test or something to start with at any center, and then maybe decide if the patient may need a manometry and refer the patient to somewhere else.
I'm sure you're right. That's the major limitation of imaging. You might be able to do more than a few minutes, but you can't do a few hours, not at current prices.
Yeah.
Anyway, so I'm very grateful to all of you for such a entertaining discussion, such a wide-ranging discussion. Heinz, as lead of this entire process, can I ask you to give just a few words to tie this all up and send us on our way?
Thank you again for all of us who contributed in person here at this live discussion, and also to all of those who had sent in their questions, which really have enriched discussion very much. I think the both guidelines, both the 13C guideline and the H2CH4 guideline, have summarized much of knowledge and much what is being done right now in clinical circumstances. And at the same magnitude that it suggests how to proceed, it also provides a starting point for many future research projects. We have identified here in this discussion many open questions in regard to many of the 13C tests, open questions in regard to much of what we have talked about in malabsorption intolerance, SIBO, and in transit. So I think it's an exciting time, and we should use this opportunity to go ahead, think about hypotheses, device protocols, and bring those into life. We have brought together in this process of guideline creation a very lively group of the hydrogen breast test group, which also includes the 13C breast test groups, of almost 50 persons out of 17 or 18 countries. This group even has increased since we had finished the guideline. We now have a colleague from Russia in this group. So I think this is a very good group, a very scientifically very sound group for future studies to perform. And Oleg is one of them. Hi, Oleg. Thank you.
I'm from Ukraine. not from Russia, from Ukraine.
You are from Oleg Shvets from Ukraine. Yeah. Oh, sorry about that. I didn't want to. Oleg Shvets from Ukraine.
Another international incident. Well,
yeah.
Near incident.
Exactly. Yeah. Right.
But we are talking about science. We are not talking politics.
Absolutely. So thanks again, everyone. I wish you all a fine day, morning, noon, or night, wherever you are. And until the next time we meet, perhaps at Ascona 2022 at the beginning of May. Goodbye.
Goodbye.
Thank you. Bye.
Goodbye. Goodbye. Thank you.
Goodbye. Thank you very much.